Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I have the pleasure of being joined by Dr. Pia Gandhi, a board-certified pediatric dentist practicing in the Houston area who focuses on functional pediatric dentistry with a practice dedicated to the detection and treatment of issues associated with airway, sleep, speech, feeding, and growth and development. Dr. Gandhi is particularly interested in the diagnosis and treatment of tongue and lip ties, especially in infants and children with airway disorders. And her passion in this arena stems from personal experiences and challenges with her own daughter, Syra. We'll actually be talking about this more during today's show. Dr. Gandhi advocates for a comprehensive team approach utilizing the Function First model, and she's built a network of practitioners in the greater Houston area to facilitate comprehensive care for patients. That is also something we're going to discuss during today's show. She is a TOTS trained provider, an affiliate of the Breathe Institute, and an active member of the American Academy of Pediatric Dentistry. In our discussion, you'll learn Dr. Gandhi's personal and professional journey, how she got to this point in her life, and an interesting part of our past that we share, how and why she began incorporating airway-focused treatment, including the release of tethered tissues, into her pediatric practice, her message to parents who have a child suffering from pediatric sleep disordered breathing and its associated comorbidities, her advice to our colleagues who do not believe that the dentist should play a role in the detection and management of airway issues in our patients, and much, much more. So without further ado, let's get on to today's episode with Dr. Pia Gandhi. Enjoy the show, everybody. Welcome to the Doc Podcast, Pia.
Thanks for having me. I'm very excited to be here.
I'm excited to have you on and talk about your journey in all of this. We were just talking before we hopped on that we're in the middle of a little interesting weather in the South here. You're getting some Houston snow.
Yeah, which is a rare thing and also funny as a native New Yorker to see an entire city shut down over 2 to 3 inches of snow.
Right. Yes, I know. It's same as a native New Yorker, which we'll get into a little more in a minute. A bit of our similar background that we discovered when I'm now in South Florida, and it's like below 50. I mean, hurricanes, they're nothing. They're like, bring it on. 45 degrees.
Yeah,
It's
exactly.
like no one can function. It's so funny how we all are and adapt to our environments, which actually in an interesting way probably gets to a lot of what we're going to talk about on why people don't want to change, right? And a lot of what we do and we have talked about, but So starting with that, tell me about your story, how you got to this point, both personally and professionally. You have a really cool journey, and we have some common threads along the way that we have since discovered. So get into that. Tell the audience about how you got here and how you got to this point in your life.
Yeah, so I'm a native New Yorker, went to college in Atlanta, and then ended up back in New York at Stony Brook for dental school, which I didn't know what I was getting myself into. Tended towards pediatric dentistry during dental school. A big part of that was one of my professors, Dr. Fred Ferguson, who I actually ended up renting his basement apartment for 3 years of dental school. So I also used to joke that he was like my dental school dad, but he was the head of the pediatric department and always said to me, like, you should just go into peds. Like, when we were graduating, he was like, just apply for residency. And I was so ready to just like get out there and start working. And so I didn't do the pedo thing at the time, did a GPR instead, started working as a general dentist, and 6 years later ended up in pedo residency. But again, not with any idea that it would take me into functional peds or airway. It was just as a general dentist, I was still like very much drawn to treating children. And the biggest factor for me to actually go back to residency was after I had my first daughter. I thought to myself, well, I would only take her to a specialist. I wouldn't take her to a general dentist seeing kids. So it's almost unfair to me to ask other parents to come see me versus a specialist. And so it just changed my perspective being a parent. I mean, like so many things, no one can teach you what it's like to be a parent or what it feels like to put your child in someone else's hands until you live it. And that was, pediatric dentistry was always in the back of my mind. But to me, that was like, okay, if I'm going to do peds, like I'm going to do it right. I got to go back to school. So that's what I did. I was already here in Houston. My husband at the time was a Texan. We met in New York and ended up migrating down here about 15 years ago.
Hmm.
So my life was here and we already had a kid and he had his dream job. So Houston was the only program that I really applied to. And it took me, honestly, a couple of years to get in because it was so
Hmm.
competitive. But best decision of my life was to go back. 2 years is like a blip when we talk about like the span of our career in life.
Hmm.
And so at the time it felt like, oh my God, 2 years of school and not earning anything. But honestly, it was so worth it. And now that I finished that in 2017, and again, like even the idea of what I was going into pediatric residency for, which was to practice bread and butter pediatric dentistry, I'm not even doing that. So it's just
Hmm.
funny the journey that life took me on.
Yeah, that's why I love hearing people's stories and journeys, because everyone sees us and where we are, and it's human nature. We see somebody, we think, oh, they've just always been Dr. Pia, who's got this great practice in Houston, but you had a story and a journey. And so many times, a common thread, and repeat and routine listeners of my show know this, is along that journey, a couple things happen. One, you have somebody who sees something in you or mentions something to you or believes in you in a way that maybe you didn't see or realize or believe in yourself. And they call something out of you or get you thinking about things a little differently. In your case, it seems Dr. Ferguson, who we'll come back to in a moment, was somebody who saw something in you that got planted that little bug in your ear, like, hey, like maybe this is something. And the other thing is, a lot of them, the people that I interview and speak with, they had some time doing general dentistry, even if they became a specialist. And that's orthos and pediatric dentists and oral surgeons and prosthodontists that I've had on the show. And a lot of them did some time in general dentistry. Do you feel like that helped you that time?
I think if I would have gone straight to pediatric dentistry, I wouldn't have appreciated the specialty as much or just the process of becoming a specialist. When I was a general dentist, the thing that I hated most is I felt like there were so many things and I couldn't possibly be an expert in any of them because there was almost too much. And
Mhm.
so, like the personality type I am, I was like, I want a focus. And I always tended towards children where I could just really do something great and do it really well. And Fred, from the get go, I mean, he obviously knows me personally very well, would always say, you are going to go outside the box and you're going to make waves. And he was like, but he always told me, but there's going to be resistance. Expect the resistance because you never do anything by the book. And so I don't think he knew 20 years from now I'd be here, but he obviously saw something. I mean, he's been around so many dentists and students and people,
Mhm.
but it's so funny because his voice will still like play in my head especially when I'm facing something challenging and it's like, well, not everyone is on the same page as me. His voice comes back and it's like, you're going to make waves and it's okay.
Yeah, and
So,
having been taught by Fred Ferguson, myself, mentioned on this show, actually my episode with Kevin Boyd, we got in really into it, and he was fascinated when I was telling him the stories about Fred. And that's one of the reasons I've actually said that I was able to go treat younger kids in my practice. I was a solo practitioner from the beginning. I didn't work for anybody. I was in my own practice from day one. And I wouldn't have had the confidence to start treating even 6, 7-year-old kids. I know that's not younger by, a lot of people's standards today, but we start talking about doing treatment that young. I've said on the show often, most orthodontic residents aren't treating a 6 or 7-year-old ever, like as in ever. So you may get 1 or 2 7, 8, 9-year-olds if you're fortunate in certain programs, but maybe do an expander on them. But you don't treat a lot of young kids. So in dental school, I had to rely on that training. I think in my residency, I did 2 phase ones, maybe 1 or 2. I mean, not much.
interesting.
Yeah. So
Yeah.
for Fred to have been the one that came in and shaped the way I thought, it gave me the confidence because he's just such a dynamic teacher. And when you said you hear his
Mhm.
voice, I was laughing at myself because I'm thinking, I literally to this day, when I'm teaching now residents, will emulate him. And when I would be practicing on my own, I would hear his voice saying
Yeah.
things like you got to own it, Hoss. Like they can
Yeah.
sense your weakness. They can sense that you don't know what you're doing. And just, I mean, so profound. So it's amazing how we have certain teachers and certain people in our lives that will speak to us. And that is something that clearly did to you. And he saw that in you, right? I mean, he saw in you that you were somebody who was going to do things differently. So I'll use that as the segue into start our conversation on what you do that's different. So explain a little bit, because I have non-professionals too that listen to the show. What is typically
Sure.
thought of as a pediatric dentist? In other words, what does a pediatric dentist typically do in a day in practice? I know that varies greatly, but just on average. And then how do you and what you do differ from that?
Yeah. So typical pediatric dentistry, which is what we're mainly taught during residency, is treating children and screening them for cavities, doing cleanings. Yes, screening when they're ready for some orthodontic treatment, but mainly due to just crowding of permanent teeth. But yeah, mainly cleaning, x-rays, exams. If they have cavities, filling, some crowns. Sometimes that can involve sedating a child if they're really young, and behavior management. Obviously, we're asking kids to do things that they don't want to do. So a lot of our training is on being able to connect with a child and manage their behavior during treatment and just during a regular dental visit.
Mhm.
We do touch on some education with the parents in terms of diet, but more so related to cavity causing foods, not really whole body health type stuff.
Interesting. Okay. Yep.
And we do touch on things like what kind of toothpaste to use and brushing technique. So that's more like if you're a traditional pediatric dentist, you're going into the office, you're doing lots of examinations, cleanings, fillings, crowns, basically things that an adult dentist would do, but on
Mhm.
kids. What I do is quite different. I practice what's called functional pediatric dentistry, and that is really looking at the relationship of oral growth and development and facial growth and development and health and how it impacts our entire body,
Mm.
specifically our airway, the way we breathe, the way we sleep, the way we speak, how we chew and swallow things. And so it's way beyond just looking at teeth themselves.
Yep.
Do we do all those things that general pediatric dentists do? Yes, but we get much deeper. So what we are looking at is screening children for growth and development discrepancies, breathing disorders, sleep disorders, speech disorders, feeding disorders, behavior red flags. And we are looking for the root cause that we know can be closely related. And so the conversation and the education in our office looks very
Mm.
different. On every child, we use something called the Ferris 6
Mhm.
screening, which is a research-backed screening protocol. It is the 6 factors that elevates a child's risk for what we call sleep disordered breathing, which is an umbrella term for everything from mouth breathing to full-blown sleep apnea.
Thank you. I just
Um,
gave a lecture at
we
Winds of
also
Change about that exact spectrum. So thank you for the way you explained that.
um, we also couple that with some intake forms that the parents fill out. So a sleep screening, a functional questionnaire. And for some of these families, I mean, they were coming to our office simply for a cleaning and a checkup.
Mhm.
And we are screening every single child, and we're having parents watch educational videos about all of this.
Mm.
And so for some families, this is all brand new information, not on their radar. Honestly, not something that they may be even concerned about. But our goal is to give everyone a baseline
Mm.
education and then meet them where they are in their family process. So for some families, they don't want to hear anything about this and they just want to get their teeth cleaned and go on their way. And that's okay.
Mhm.
I mean, it's their family, it's their child. But for others, we're bringing to light something that may have been on their radar that they had no idea is even connected to dentistry
Mhm.
and oral facial growth. And so we go from just like planting a little seed to like going into a full blown in depth conversation with some of these families on a visit. So some of this, when you practice this type of dentistry, is being able to read the room very carefully,
Mhm.
because I've had people leave the practice because it's too much for
Yeah.
them. But I can't see something and not say something,
Yeah.
because even if parents don't want to go through with any of the further discussion or any treatment, I feel like I would be doing a disservice to that child and that family if I didn't at least bring up something that I'm seeing that could impact them now or down the road.
It's such a great answer. I love, first of all, I love the approach, and I give you so much credit for being outside the box. Clearly, it's who you are. And as in we talked about, as Fred saw in you, I don't want to, I want to make sure not to understate the fact that's not easy. So what you're doing, especially for those who aren't in the profession, is not easy to break from the pack, to do things a different way. And like you said, you have to be willing to lose patients who just aren't going to buy into what you're trying to do because it's newer and it's different and they just want the routine screening and filling as needed, et cetera. And I love that you also said, that's okay. Like, that's okay. I'm not going to force anybody to do this. But at the same time, it's my responsibility to evaluate each child in that manner and capacity, educate them as to what I'm seeing, and then let them decide. So going on that theme for a second, could you just give an example of something that may not be picked up or detected in a traditional pediatric dental setting that you, or you can give a couple examples, that you might see? And then, because I find one of the tough parts is we don't necessarily know how to screen because we're not really taught this. And then once you see it, how do you go about educating them and explaining to them the problem with it? So how do you detect it? What's their process for detecting it? And then for explaining not only what it is, but why it's an issue?
Yeah. So one thing I would say, like mouth breathing, for
Yep.
example, first sign of a breathing disorder, something is not right, whether that's habitual or we're an allergy kid that's constantly stuffed up, or we have large tonsils and adenoid. The initial response sometimes I'll get when I bring up, oh, I noticed that your child has their mouth open. Are they always like this? And then I start to asking them some sleep question. A lot of times they'll say, oh, well, I mouth breathe. Is it a problem?
Mm-hmm.
And then I just explain to them, mouth breathing, we do not oxygenate our body well. When we're mouth breathing, we're taking in unfiltered air. That increases our chances of inflammation of the tonsils and adenoids, which will further block the airway. And usually when I start telling them, it also will start changing the way we grow.
Yes.
Then they will start looking at their own face and say, oh yeah, I noticed. And I had braces 3 times. And I'm like, well, one of the reasons why you may have braces 3 times is because a lot of times we just look at the teeth and we're not looking at the muscles around it and the way we're breathing. And so if we want to avoid that, we have to look at a couple of these things. And so then sometimes they're like, oh, I didn't even notice that like the mouth is open that much. Or they'll say, well, their mouth is open, but they're not breathing through it. And I tell them, if their mouth is open, they're breathing through it.
Right.
That's just the only reason they would have it open. So sometimes the conversation stops there and we just give them some information about mouth breathing. But I also tell them then I start asking them, what do they look like during sleep? Do they have drool on their pillow? Are they moving all over the place? And this is the same kid that's probably in my chair, like bouncing all around.
Yep.
Can't sit still, right? Like all over, touching everything. Even though there's a TV above their head, it's like they can't handle it.
Do you
right?
want to explain why that is?
Yeah. So kids that are not sleeping well present as hyperactive. And sometimes it's hyperactive, but they're still performing well in school. They're keeping it together. Other times, we have prolonged poor sleep and it starts to impact our learning and our behavior. And ADHD is definitely a thing, but this can mimic ADHD and it may not be ADHD. And I've had many cases like this of kids that are just not being able to focus at school. They've been medicated or their parents are worried that they're going to be medicated. And so it is more breathing and sleep related. And I know as a parent, I didn't get into this until my daughter was about 3, and that's how I got into this. But I was never educated on what sleep should look like. I was just educated on here are the number of hours, make sure your child's in bed at this time. No one told me that a child should be a silent, still sleeper. That is a rule of thumb. If anything else is going on, heavy breathing, grinding, it doesn't have to be snoring in the traditional sense. That's not normal. Our kids shouldn't be like falling off the bed or upside down on the bed in the middle of the night. So that is a big thing that parents know nothing about.
Yeah.
And how are they supposed to know, right? We're not educating them on it. No one's talking about it.
Yeah, I was going to say, I venture to say most of our colleagues, and I don't mean this as an insult, it's just a fact, that don't know a lot about it. Wouldn't you agree?
Yeah, in the traditional pediatric office, if I could tell other pediatric dentists to start looking for a couple of things that I think are easy to see.
Yeah.
One, mouth breathing. And you can see that you're having a conversation with a parent. Just look at the kid. Just see what they're doing. Chap lips. Dead giveaway. Okay. So just start looking at that. The other thing is we're taught in residency that a palate is narrow if there's a crossbite. Yes. A palate is definitely narrow if there's a crossbite. But if there is no interdental spacing in primary teeth, it's crowded. That's considered crowded. So
And Bogue knew
look
that
for
back in
that.
the 19 teens when he
Yes,
talked about that.
yes.
Yeah.
So if you just look at that, you're doing your exam and you see no spacing, you're already in trouble.
Yep.
The other quick and easy thing you can do, I mean, we have bully gauges and we measure every single child. You don't need to do that. Take a cotton roll, try to stick it between the primary molars, second molars. If it doesn't fit, that's about 30 millimeters. By 4, if that doesn't fit, you're already trending on narrow. Look for other signs of what? Look for other sleep signs, breathing signs.
And what do you tell them when they say, well, what's the big deal if they're narrow? Everybody's different, and that's fine.
Yeah, so again, it's about where the conversation is going. If parents are not concerned about sleep, most parents are concerned about crooked teeth when permanent teeth come in or crowded. So you have to tie it to wherever their concerns are, and then you can educate them about the rest of it. So what I tell them is if they're 5, 6, 7, and they're approaching we're going to lose teeth, well, if you can imagine that a permanent tooth is about 1.5 the size of this baby tooth that's sitting here, and we're going to try to fit 4 of them up here, they have nowhere to go. And they're not going to be able to fit in. And then we're going to have very complicated orthodontics early. If we can spread things out now, we are less likely to have crooked teeth come in because they can start shifting around in the bone and come in more straight. So I try to tie it back to that, the more the orthodontic straight teeth vanity piece. If we're not really concerned about sleep at this point, or if they're not seeing what I'm seeing, because for most of those kids, I'm already seeing red flags. But if they're not seeing it, I'm not going to convince them to move forward with anything if I go off on some tangent about sleep that I'm concerned about, because they're not concerned about that. So we're going to bring it back to something that makes sense to them. The other one that I find makes sense to parents that they bring up is grinding, because it sounds so horrible that they know that can't be right.
On grinding, what about what so many of us were taught, that it's just a normal part of the development and exfoliation process that kids go through? I'd love to hear your thoughts on that.
Yeah, I would love to see the research on that. And the only time I tell parents it's normal is young toddler when they're getting teeth in, or their language, they don't have the language. It's usually daytime grinding too. When they don't have the language to express what they want, they grit their teeth, or they physically express, they're trying to express. But other than that, it is a way to keep us stimulated while we're sleeping. It's a parafunction. And evolutionarily, I don't know why we would have a thing that would be where we grind our teeth down so they're little nugs. I mean, that makes no sense.
Right.
So again, once I explain it to them, and when they see the wear, they get really worried. This can't be normal. But the one battle that I have with this grinding conversation is, well, can't you just make a night guard? Or I've had other pediatric dentists make night guards for 4 and 5-year-olds. And I'm like, well, now we're restricting their growth. So that's a problem. We don't want to do that. And again, to me, that is, we're putting a Band-Aid on something. We're not figuring out the root cause of why they're grinding, which is airway related.
Yeah, it's somewhat analogous to a few years later extracting permanent teeth when they're crowded, right? I mean, you're still just treating the symptom at the end of the day. You're not getting at the etiology. And this is obviously kind of an off-the-cuff question and something I know you don't have the exact answer to, but I'd love your thoughts because you're so well versed in this. How many for now, just speak to the pediatric colleagues, do you think have any idea about what you just spoke about from a mouth breathing and of craniofacial growth and development, bruxing, understanding the comorbidities associated with that? What percentage of your pedo colleagues do you think have that on their radar?
I mean, it's low. I would think like 10
Wow.
10 to 15%.
Wow.
And I'm just thinking of, like, I'm in a very dense city with a lot of pediatric dentists.
Sure.
And I'm just thinking of the fact that there's myself and maybe 2 others in the 4th largest city in the country that talk about any of this, that do any of this. And I mean, they're in my area. Within 3 miles of me, there's like 6 pediatric dentists. And I have people that come to me from all over the country, but all over Texas. Most of my patients in one of my offices travel at least an hour and a half to 2 hours to come see me. The majority of those patients in that practice.
It's I'm not surprised by that. I saddened but I'm not surprised because I get messages. A week doesn't go by where I don't either get
Yeah.
message on Instagram, Facebook, or an email, or all of them from a parent who follows my content or who has found me on social media and says, "Can you please recommend someone in X area for me?"
Yeah.
Because I've gone to 3 different pediatric dentists or orthodontists or whatever the case might be, and I know this is a thing, and I know my child's struggling, but everyone keeps telling me they can do nothing about it. I even have true story, Pia. I have multiple orthodontic colleagues who reach out to me and ask me what to do because they don't know what to do with their own children at a younger age because we're not taught. And I say to them all the time,
Yeah.
number one, don't feel bad because they almost feel like ashamed. Like, I can't believe I don't know what to do with my own kid. And I say, we're not taught this. We don't learn this. And it's sometimes not until, as you alluded to with your daughter, it's not until you see it in a different capacity that you can maybe either yourself or a loved one, that you can maybe have a different appreciation for it and understanding of the importance of it. It's just so amazing to me that our educational process still isn't incorporating
Where
these concepts. Like, what is going on?
Yeah, it's I think the parents are driving a lot of this. And I think what's going to happen is the colleagues that are not doing it are hopefully going to get enough patients coming in asking for it that they're going to say, "Oh gosh, maybe I need to educate myself on this," because they're knowledgeable now. They're seeking it out and they're asking the right questions and they're looking for providers. I mean, sometimes they'll come into my office and I'm like, "Wow, I mean, did you take all the courses I took?" Because they know
Yep.
so much. And the thing they know also is they know their kid.
Yes. Thank you.
And that is something I don't know.
Right.
But the thing that gets me is that so many of these parents, myself included when I was going through this, will take their concern to a practitioner and get totally dismissed.
Yeah.
Or feel like they're crazy.
Yeah.
Because this practitioner is telling them, "Oh, no, that's not right."
Yep.
And what they need to know is they have an instinct and they know their child.
Yeah.
And they know something is not right. And what they're looking for is a practitioner to listen. Even if you don't know the answer, at least listen. But so many practitioners are quick to dismiss. I mean, just this last week, I had a mom in there saying, "Thank you. Do you know how much it makes me feel like you saying, like, validating me?" And she looked at her husband. She goes, "See, I'm not crazy."
I had it happen all the time.
And she repeated it so many times.
Yeah.
And I was like, I feel you.
Yeah.
Like, I totally understand where you're coming from. And then the second to that is that even though they were dismissed so many times, they will say, "Thank you for validating me," but they will still have so much guilt associated with the
Yes.
fact that they didn't do something about this sooner.
Yes.
And it's not their fault. Like, I am in the dental field and it took me a while to figure it out on my own kid. And I have the opportunity to learn these things and practice these things. But the guilt that these parents feel is it's devastating to watch. And that's one of the things that, like, as practitioners, we need to educate ourselves better. We need to provide this education to them and validate them and care for their kids because they can't do it themselves.
They can't. And I saw that guilt too. I mean, I had parents break down. Sometimes they'd come into me 10, 11 years old, and it was the first time I'd see them. And I was always very sensitive to not be like, "Oh, geez, I wish I saw him 7 years ago or 6 years ago." I never would say that to a parent. Sometimes you get asked, like, should this have been something we should have done earlier? And obviously, I always tell the residents, you never ever lie to a patient or a parent. That being said, you sometimes have to phrase things in a manner that is not going to be overly critical of someone else. And what I say to those people is, unfortunately, in our training, we don't get a lot of training, speaking from the orthodontic side, on what to do with these kids who aren't growing really well when they're young. We get a lot of training on what to do with them once they've grown poorly. And that's just what it is. And I know that's not a great answer. I know that's probably not the answer you're looking for. And I would say to them, this is one of the reasons why I'm going to go out in the future and teach more on this, because the message has to get out there. But that guilt's real. And I would have moms say, like you said, I knew it. I've been telling the pediatrician for 3 years, 4 years, but they kept saying, "Oh, they haven't had strep 5 times." And just was on the phone with someone yesterday who their child has seen multiple ENTs, pediatric ENTs, and won't do anything on a younger child. So I'm trying to connect them with a pediatric ENT in their area who is more aware of these issues. So how do you handle those two situations when parents say to you, I'm guessing probably that they do say to you as well, why are you the only one, or why is no one else saying this?
Yeah.
Why do I have to drive 2 hours to you or fly to you or whatever the case might be? Number one. And number two, when they were, and this will transition to us talking about how you assembled a team, when they can't find a medical provider to follow up on what you've recommended.
So I get the first question a lot. Either my kid's been going to a pediatric dentist for years. This has never been brought up. Why are you talking about this? And similarly to what you say, I tell them the education piece, but I also share my story, which is the only reason I really ended up here with my older daughter, because from the get-go, poor breastfeeder, like every red flag you can think of related to tongue tie, which we know the tongue is so important. That airway development starts then, right? So if the tongue is not working well, we're just setting ourselves up for failure from the get-go. But I got bounced around, told to bottle feed. About around 3.5, she was the child that would just like break down and tantrum after tantrum with no rhyme or reason, audibly snoring. And her dad's a physician and was like, she's fine, and at least I knew about tonsils and adenoids. I was in residency. Anyway, we got them removed and marginally better, but still mouth open breathing, venous pooling, still crappy sleeper. And then I took a course by Dr. Zaghi, and he was literally talking about my child. And that no one was expanding at that age. There was not. She's almost 12 now. There was no like interdisciplinary, approach, myo, chiro, all those things. So I released her once with not a lot of pre-work, and again, marginally better. And then it took me on this, like, again, my instinct was like, something's so wrong with her. This is not right. I had to figure it out. That started my journey as a practitioner to expand. My 12-year-old has probably been through everything that I've learned. She looks fabulous, and she sleeps well and breathes well now. But that poor kid was in a myo brace, removable expander, fixed expander. You name it, I did it on her. But that is what kept driving me and kept pushing me to educate myself more and more. So when I talk to these parents, I tell them, I said, the practitioners that are really deep into this, most of us, it's because this was missed on our own child, and we had to figure it out. And I say, once I saw the impact that it had on my own child, I couldn't help but I obviously had to help other families. And because I know that my Syra would not be what she is today if I hadn't done all those things. And once I share that with them and give them context, I make it a point to say, you don't have a bad pediatrician, and your previous pediatric dentist is not a bad practitioner. They don't know what they don't know.
Right.
And so it's just, we have taken it upon ourselves to educate ourselves because we see the importance, and it's a matter of time. It will get more widespread, but we're not there yet. And so in terms of the team approach, which is what we're all about, because you can't just do a tongue tie release or put an expander in a kid without looking at the entire airway, looking at tonsils, adenoids, sinuses, allergies, myofunctional, habit. Everything, body alignment, postural tension. You got to look at the whole body. And so we are very much a team approach. I have everyone in-house. I have myo, chiro, SLP, everything in-house, but not everyone lives close enough to utilize our in-house practitioners.
That's so great, by the way. You have everyone in-house. Good for you. That's awesome.
Yeah, it's awesome. It's a great learning opportunity for me to be able to work literally side by side with all these practitioners. But we still heavily utilize community partners because, again, we don't expect everyone to come to our practitioners. We implemented it as a convenience for people that didn't want to go to one more place. But what we've also tried to do is, through going to conferences and being a part of Airway Circle and the Breathe Institute, is really partner with people all around the country. But whenever I lecture, and one of the lectures I do is with part of my team with a myo, a chiro, and a lactation, we always talk about, because we're educating other practitioners on how to do this, we always talk about ideal versus real. So in an ideal situation, everyone would have a practice like mine, all in-house practitioners, you can offer everything. But the reality is some of us are in rural areas where there is no chiro that specializes in this, or there is no myo.
Yep.
So my philosophy is some is always better than none.
Yep.
So if you can do a virtual myo, okay, maybe it's not as good as in person, but it's better than nothing. If there's not a chiro, okay, like PT, or in some states, chiros can't work intraorally. So then having the chiropractor teach the parent what to do intraorally. There are some practitioners that I work with that initially they didn't have any of the certifications. They were just interested in it. But those people that are passionate and interested, it's worth investing time to educate them and help them get more well-versed in this, because then they will be your greatest asset. So even if someone's not there currently as a practitioner, if there's someone interested, invest in them. And then learn some things yourself, like partner with a myo, learn some basic things that you can have patients do. Again, is it ideal? No, but it's better than nothing. So I find a lot of practitioners that are trying to get into this, if they don't have the ideal setup, they back away.
Yeah.
They say, oh, I can't do it. If I can't do it the way you're doing it, I just can't do any of it.
Yeah.
And that's not true. You can certainly help patients with the resources that you have.
I love it. And the ideal versus real, it's so great because especially as orthos and pediatric dentists and dentists in general, we are minutia focused. We want everything to be right. I mean, it's our training. It's in our blood anyway. It's part of the reason a lot of us went into this field, and then it's exacerbated through our training. And so I feel like a lot of people, unless they know they can do it well, and I think that's a big reason why a lot of orthodontists won't branch out into this arena, because a lot of them have gotten really good at straightening teeth. And it works in their system. Their office runs well. It's profitable. It's successful. They're not in that moment in time harming anybody. They're making patients, we could have a debate on that, but look better, right? And happy. They don't have to follow up with them 10, 20 years later to see where they are from a health perspective or an airway perspective or a relapse perspective, because most patients move or aren't in that same area anyway, even if they come back to the need treatment. So it's hard to motivate somebody to change and get out of their comfort zone. And when I referenced speaking at the Winds of Change meeting this past weekend, which was awesome, and huge shout out to.
I saw some posts about it.
Yeah, huge shout out to Maz Mashiri and Reza Movahed for putting that on. And it was really just, it was a collaboration of dental providers and physicians and myofunctional therapists. And it was just really a neat group there. And it struck me that, well, I had a lot of conversations with different people. And one of the things that struck me was when someone said to me, we were talking about it, they were referencing my talk that night. And what I was talking about with calling out very fairly my orthodontic colleagues for not wanting to look into this more. And they said, it's got to be like they're driving this big ship. They didn't say the Titanic, but in my mind, like the Titanic. And you're trying to change course, right? So I said, I'm going to use that as an analogy. If you got the Titanic heading towards the iceberg, it's not as easy to turn that thing as people would like to think. You would like to think, just turn the ship, like don't hit it. But by the time you're down that path that far, you can't steer that ship in a different direction that quickly. So analogous to, I can't speak as well for the pediatric dental group, but for the orthodontist, you got a practice that's humming along. You're seeing 75, 100 patients a day. You're going to all of a sudden just totally change your practice model. And that's the next part I want to talk about is one of the things I was talking about in my lecture was I wanted people to think about, why should they care? What should motivate them to care? Because if you don't care about going outside the bounds of what your comfort zone is, your motivation was your daughter, right? So many people, as you said, that's the case. That was your primary motivator. It made you care about this and see things in a different way. If you don't have that, honestly, like honest question, why should most people change? To play kind of the devil's advocate, I mean, really.
I mean, what I would say to practitioners is just do one or two of these cases and see the impact that you have on these families. Because to me, and it's not just me, now my whole team, we recently did our annual reviews and we always ask them, a lot of my team commutes and I'm like, you've passed 1 million dental offices. Why come here? And so many of them, granted, I've treated a lot of their children, is they love changing lives and they know they're a part of it.
Yeah.
And that's what I would say to some of these practitioners. Okay, you don't want to you don't want to commit and change your entire practice. Do a couple of these cases, see the outcomes, and then tell me how important straightening teeth is.
Yeah.
Because that's the way I feel about doing a filling. I still do all pediatric dentistry. I do fillings. I do everything. But do I get the same satisfaction? Absolutely not. I mean, my primary motivator for going to work is the lives that I'm changing. And that is what we're doing.
Yeah.
We're not just changing the child. We are changing an entire family unit. As a parent that lived through a child that was not sleeping and not functioning well, that was a stressor on our marriage, on our daily lives, on my sleep, on everything.
Yeah.
And we have the opportunity to do something in less than a year. You totally change things.
Yeah.
So if you're not a believer, I totally get it. I mean, change is hard. And if you don't have a personal motivator, I get it. Just do one or two.
Yeah.
And if it's still not for you, fine. But I will almost guarantee you that you will want to continue to do this type of work. And I've trained a few doctors at my office because I have a 2-day clinical training program. And they just text me saying, oh my God, these results and the feedback is incredible.
Yeah.
And I will tell you, if you're worried about like a business perspective, these people now they can't keep up with the consults that they're getting. And so if you're worried about like, I'm not going to be as profitable or whatever, I mean, there's so much of this to go around. You will have people coming in from every direction. But it's the fact that this work is so meaningful that will keep you coming back to it.
Yeah, that is so well said. And it really does change lives. And I love that you said it's not just the patient, because I showed a video in my lecture this weekend of the parents, and they were actually on my podcast. They were one of the earlier shows I did like over a year ago. And the parents of a patient whose life I changed in practice coming on, and dad was a certified registered nurse anesthetist. They were up at night. Dad describes it in the video, holding their daughter's head up to keep her in the head tilt chin lift position so she could breathe at night. And she came in to see me at 6, and no one else had recognized it at this point. And she came in because of a protrusive upper left incisor that mom was worried about patient traumatizing. That's why she presented. And the pediatric dentist, mom tells the story in the podcast where the pediatric dentist told her, really, there's probably nothing to see right now. I don't think you need to go to the orthodontist. And again, I'm not criticizing the pediatric dentist. It's actually a very good pediatric dentist. It was one that was a little further north of where I was, so I didn't work with often, but I knew she was very talented. I mean, it's not even on their radar. Like, it wasn't even on her radar to ask these airway questions. And it's so interesting because the American Academy of Pediatric Dentistry, the American Dental Association, and yes, even though I'm hard on the AAO white paper, the AAO in their white paper call on dentists to screen all patients for airway problems. Yet no one's teaching us how to do it. It's just screen for it.
I think that Ferris 6 tool is so easy to understand.
Yeah, I'll put a link to that in the show notes for today. Yep.
Yeah. I mean, I currently have 2 associates, but I've had several through the years of practice, and one now does some of this intervention with me, but all of them I've taught how to screen. And they went to residency, had no background in any of this. Some of them had been practicing 10 years plus. So it's teachable.
Yeah.
They all have picked it up. Only one of them really wanted to take it to the next level and actually learn how to do some intervention. But screening, even if you just use the Ferris 6 tool and put someone in a risk category, and then it told you, okay, this person with this type of risk, maybe I should refer them to this practitioner who's airway focused. You don't have to change your whole practice to do the treatment, but at least screen, have some sort of like basic pamphlet, which a lot of like the ADA has that fleet pamphlet. Hand it out, hand out the name of someone that's doing this. And then you've done a good thing. You've covered what we're now supposed to be covering, but you've at least given that parent the direction if they want to go there.
Yes.
And I think that is feasible for every practitioner.
Yeah. And it's in line with
2 minutes.
It's in line with the recommendations of all of our organizations. And a lot of people who are in the anti-airway orthodontic movement are very quick to quote the white paper and say, well, the white paper said that orthodontists shouldn't have anything to do with airway. No, that is not what the white paper said. The white paper makes a big mistake by focusing completely on obstructive sleep apnea. It doesn't talk about, as I love you said earlier, the spectrum that is sleep disordered breathing. So it has it wrong there for sure by focusing on obstructive sleep apnea only, end stage disease. But they do say multiple times in the white paper that all orthodontists should screen all patients, especially children, for this. So any orthodontist out there who's not at least going through a thorough screening process for airway
Yeah.
compromise in their patients is on the wrong side of this. And I also love what you said of, okay, once you detect it, and I do see it going this way in our profession because it's getting so almost subspecialized where you get our specialties and then you've got these subspecialties. So hopefully a first step would be where people can have the confidence isn't the right word, but the collegiate respect where they can look to a colleague and say, this isn't my thing. I don't want to treat a 4-year-old or a 6-year-old or even an 8-year-old, right? Like, but that's okay. I detected in your child that there are these issues. So and so down the road, or even maybe at this point, a half hour away, does this. And I really feel you'd be better served there. And I challenge all my colleagues in dentistry to think beyond yourselves and
Yeah.
be big enough to do that and not try so hard to protect every patient to come to you when their teeth are crooked or when they have bigger problems or more rampant decay in the case of the pediatric dentist because they're mouth breathing and they've got all the issues associated with that, to just be willing to recognize some of these things because it's the right thing to do. And whether or not you want to have the debate over what we can do about it, it could be a whole nother episode about that. And I certainly would be happy to have that debate too. But from the very least, it is not debatable some of the things that you alluded to earlier, that the airway compromise, even mouth breathing, changes the way that the shape of the face grows. It has neurocognitive and behavioral impacts that are well documented in the literature. I actually found an article going back to 1933 that highlights
Wow.
the intellectual compromise in children who are mouth breathing and snoring.
Okay.
So
Believe
we're
it. I
going on
believe it.
100 years that we have known that this is impacting these kids more than just the fact that they're a mouth breather, say. And adenoid facies was 1870, Wilhelm
Yes.
Meyer. I mean,
Yeah.
we're 150
Yeah.
years from this. So the people who say like, oh, well, the way you breathe or sleep or oxygenate, the scientific side, as you alluded to, with the issues with purification of the air, humidification of the air is one thing, but they say, oh, it can't change the way the face grows. But then some of those same people will, you say, well, are adenoid facies real? Is that, well, yeah, if you know, that's a thing. Well,
Well, we're just, yeah.
both ways. And if they can't breathe through their nose because of allergies or terminal hypertrophy, well, it's the same thing,
Same
right? I
thing.
mean,
Yeah. I think as a profession, we need to just take a step back and go back to the fact that we seemingly all got into this to serve patients and their well-being.
yeah,
And so some of the barrier comes in of, oh, well, I don't want to give up this patient. I don't want to
yeah,
refer them somewhere else. I don't want to refer them to another pediatric
yep,
dentist. What if they take them? Well, let's just realize that there's enough patients for
yep,
everybody and do the right thing is what like you were saying, do the right thing. And I treat many of my patients for airway and orthodontics, and I don't do their pediatric dentistry.
hmm
They go back to their
hmm
pediatric, and that's fine.
right,
Collaborative care, that's what we're looking at.
yeah,
But at least I know in Houston, and I'm sure in many places, the climate is pretty cutthroat. And I
mm,
think sometimes that gets in the way, egos get in the
yeah,
way. And it's unfortunate because in my experience, when I haven't known how to do something or feel like someone could be better served somewhere else, and I tell a family that, I only get more respect from them.
yeah,
And they want to come to me for the things that I can do.
yeah,
And they're respectful of the fact that I know someone that can do this other thing better than I can
yep.
do. So why would I do it?
Yeah. I mean, that's so, again, so well said. And I find that the people who get this on the airway side, there's a bunch of common themes, and we've already talked about a couple of them, but really feeling the pain of the patient and the parent is one of them. And then realizing it's bigger than us, right? Like
Mhm.
this isn't just about the control over getting every patient. Because in the orthodontic industry, I'll be honest, I've had a lot of orthodontic colleagues tell me over the years, and it actually really frustrates me when I hear it. I've heard it going all the way back to when I was a resident faculty. I've heard it from where they'd say, don't get the teeth too straight in phase one because you want them to do a second phase. I mean, that's the mentality of a lot of orthodontists out
Wow.
there. And I say
Yeah.
all the time, I am not trying to disparage my orthodontic colleagues. I look at it as it's like a family member, right? I love my orthodontic colleagues. Sometimes though, you've got to call your family out when they're not performing or upholding the values of the family, right? And I feel like orthodontists, when you do something like that, I don't feel that you're upholding the values of the profession. You
Yeah.
don't not get the teeth straighter during phase one, so they'll come back to you for a second phase. But the reason I tell that story, again, is not to disparage my colleagues. It's to just to explain to everybody out there who's listening and to the young residents and young docs, don't be that. Don't be that. Don't follow them down that path, which is about making sure that kid comes to you for full comprehensive treatment down the road. Look at it for more than that. Open your minds and expand your reality on what's even possible. On that note, do you face a lot of criticism? One of the things I hear from a lot of the people I coach and train and help is I get so much hate from colleagues, and I
Mhm.
have had colleagues going on and posting negative reviews on me, and I'm having them tell everybody all I care about is money, and I'm just trying to start people earlier so that I can make the money. And I hear that a lot from people, and it's real. It intimidates a lot of people who understand what you and I are talking about here, and they get it. We don't have to explain the why to them, but the execution of it is too much for them to handle because they're worried about the well-being of their practice.
Yeah. So I will say I faced a lot of that. Um, Initially from the tongue tie side, because that's where, when I started my practice, that's what brought me into this world, was more the tongue tie stuff.
Mhm.
And then it morphed into Airway and the ortho intervention. And yeah, there was a lot of resistance from other practitioners, from the ENT community. One of my practices about a mile and a half from the Houston Medical Center, which is one of the biggest medical centers in the country.
Mhm.
And so lots of ENTs there, lots of pediatricians. And I will say, like, and I'm actually lecturing coming up in a couple of weeks, and part of my lecture is on mental preparedness and taking care of yourself,
Mhm.
because if you don't surround yourself by believers, and if you don't believe,
Mhm.
you will get torn down over and over, and you won't be able to do this.
Yeah.
But also, if you are as passionate as most of us are that are in this field, it's almost like, well, nothing's going to stop me anyway,
Yeah.
right? Because I know what I'm doing. In my gut, I know what I'm doing is right. And I have just chosen to, I don't want to say ignore, but I don't engage.
Mm.
I don't engage in the negativity. I used to attend a couple of meetings with not like-minded people just to try to stay in the community of dentistry.
Mhm.
And I just don't go anymore.
Yeah,
Like,
same.
it's not worth it,
Same.
you know? And so it's okay. I'm somewhat on my island, but I also know that there are more people like swimming towards me. It'll happen over time, but I have to take care of myself. Like, to me, like yoga, meditation, I have to do all of those things, and I have to cut out a lot of toxicity. But I don't think you're going to win by fighting the battle head on. Like, you can respectfully educate, and then you just have to walk away. And then you just have to walk away. But, and again, I'm going to share this in my lecture, but it will go from bad reviews, and then social media is a killer. And then this past year, I had to defend myself to the board about a case. It got dismissed, but it was probably the most challenging thing I've been through in my career. And I hadn't even done treatment on this child.
Wow.
I actually had recommended just therapy. And because all of this stuff is so quote unquote new or controversial, and the people sitting on most of our state boards are older practitioners. So
And running our
they
organizations.
didn't, I mean, the lawyer that represented me was amazing, but my first call was with him. He was like, I don't even know what a tongue tie is, and I've been doing this 25 years.
Wow.
And I was like, well, okay, we have our work cut out for us. But my point is, you are going to face things.
Yeah.
You are going to face resistance, whether that's just from someone disrespecting you to your face or behind your back, to maybe having to go to the board and explain what you're doing and why you're doing it. And if you don't really believe in what you're doing, you'll run in the other direction the minute someone tells you this is not what you should be doing. When I teach people, I tell them, get the appropriate clinical training, know what you're doing. But once you have that, you're only helping these patients.
Yeah. Yeah.
You have to have thick skin, and you have to figure out how to find your zen in all of it.
I really appreciate you sharing that because I really do, because I get that question all the time from people. And I mean, I faced it. I'll talk to people back where I practice and they're
Yeah.
like, oh, people are like, oh yeah, he's doing the Airway thing. And it's, yeah, but they can't find anybody. I have family and friends up there and I get contacted frequently. And they're like, is there anybody up here who thinks like you thought and does it that way? And I can't find anybody who's willing to even entertain more proactive treatment or airway-based treatment. And I said, no, it literally happened 2 weeks ago. I had someone reach out to me and ask, and I'm like, no, sadly, there's not still. And that's upstate New York. It's certainly not a rural area. There's rural parts of it, but this is around the Albany region. I mean, there's lots of practitioners up there.
The other reason, like I share that about the board and all of that, is because I think sometimes people get the wrong idea when you're doing this. Oh, it's also, everything is perfect. You like you said, everyone took a journey. We didn't just like end up here magically. But anyone can do it.
Yeah.
It's a journey. It's a process. You're going to face things. But if you really want to do it, you can. And it's really rewarding work.
And it makes it, correct me if I'm wrong, but on my side, I can at least speak to it that all the noise, all the hate, it didn't even come close to drowning out the praise and the gratitude I was receiving from the patients and the parents, right?
Yeah.
Not even close. I mean, it literally was noise. I was just like, yeah, whatever. I mean, now when it crossed over, I had some colleagues say that would tell patients that I was committing malpractice. And so I dealt with that head on, obviously, because that's not acceptable to do that. But for the most part, it was just people making comments and they didn't want to learn. I offered to teach anybody who asked me about it, where in the area I was practicing. I said, I'll teach you. I will sit down and I will explain to you what I'm doing and why I'm doing it. No one ever took me up on it.
And I'm the same way. Like, people can come observe me anytime.
Yeah.
In the office.
That's what I said. You're welcome. Come spend a day with me
from day one.
Yeah, like even to sort of quote unquote competitors. I was like, come spend a day in my office. I don't care. Like, yeah.
And the pediatric dentists, I would really encourage them to look at this more closely. I know from the orthodontic side, it would be great if more orthodontists got on board, but the reality is your behavior management training is never going to be what we learned.
Fair.
And you can start. So, I mean, I expand as young as like 18 months old when we're seeing these things. But sometimes we're putting in expanders in a knee-to-knee position. No orthodontist is ever going to do that.
Yeah.
But as a pediatric dentist, that is totally in our wheelhouse to deal with a patient like that.
Yep.
So I really would encourage our pediatric colleagues to start looking into some of this, because we have the tools to treat some of these really young ones that no one else is going to touch.
That's great advice. And I agree. Yeah, that's a big drawback. It's one of my missions in the orthodontic, now that I'm on the academic educational side, to start to incorporate some more behavioral training. I mean, as we started talking about earlier in the show, a lot of orthodontists don't know how to treat a 6-7-year-old kid. So the thought of treating a child 2, 3, 4 years of age is just so far beyond the reality. And because they haven't been exposed to it and heard that it's a thing, it instantly becomes something that, well, then it must not be a thing, right? Well, maybe we should look at this more. Maybe we should educate more. And that's one area I do want to call out the AAO on. Is I agree that AAPD, ADA, AAO have all talked about the screening part, but where the AAO's fallen short, in my opinion, and this is where I think the white paper did do a lot of damage and continues to, is it said for children, once we detect there's an issue, our role as an orthodontist is to refer the patient to the physician to make a diagnosis, and then we perform treatment as directed by our medical colleague. And I feel like that's a big problem. Again, as I said, it's tied to the fact that they're talking about OSA. So they're literally only talking about OSA. So they're basically saying you can't diagnose OSA. Well, of course, we know that, right? You need polysomnography and sleep study, which we could go into the challenges with those and the lack of validity in children. Again, whole nother episode. Yeah. But even if you want to go with it, let's just say that it's valid, right? Then not everyone has access to these tests. Not everyone's going to be at that level. And maybe you're catching them on the spectrum earlier than when they have that level of end stage disease. Maybe.
Well, that's the point.
That's the point. And so by just making about the OSA, the fact that it's OSA, and then we can't quote unquote diagnose or treat OSA, they punted back to the physician and they essentially said, we can't. And you know what the end result of that was, Pia, that everybody who doesn't want to believe that the orthodontist can play a role in Airway took out of it? It was that the orthodontist has no role in Airway. And that's the sad part, because I've called on AAO and I'll continue to do it. Get a white paper out there that talks about the spectrum that is sleep disordered breathing, and especially in children.
Because once we've hit OSA, the damage is, I mean, we've done so much damage already.
Exactly.
When we know if we can just pick up on the early signs
Yes.
and de-risk, it's all about de-risking the child.
Yes.
So we know narrow palate, mouth breathing, those are all risk factors. Well, let's eliminate those risk factors so that we don't even get to the OSA. And I did want to touch on something. You said parents listen to this podcast, and I get questions or parents that are afraid of the process and what it looks like. And how can you do this on such a young child? Isn't it painful? Do you have to sedate them to put the appliance in? I mean, I get all these questions.
Yep.
And I did want to say, like, it is, at least all the extenders we make, they're 3D printed. They sit on top of teeth. They don't impinge on gums. Putting them in takes 5 minutes. It's a quick try-in, like trying on a shoe, and usually they fit perfectly. And we just put some cement on. Most of ours are fixed, meaning glued into the mouth. And then we put it in, we cure it with a light, we give the kid a popsicle, and they go on their way. And so a lot of parents that have experienced expansion on themselves, it was with traditional orthodontists, older,
Great
where the
point.
bones were less pliable. And oh my God, it was so painful. I don't want to put my kid through that. Well, the really young ones, especially, we do a very gentle expansion schedule. So they barely even feel anything that's going on.
Yeah.
For the really little ones, where the parents are like, there is no way I'm getting in there with some key and finding a small hole, we use spring-loaded ones.
Yep.
The memory expanders. And that is literally set it and forget it.
Yep.
And we see them every month or so for follow-up, take some measurements. A lot of times it starts out in a knee-to-knee position, but then that kid is doing so well. By the end of treatment, they're sitting in a chair at 2.5 years old. So initially when parents come in, I think some of them don't come in because they're scared of, oh my God, this is like going to be such a horrible experience and my kid is going to be in so much pain. I have yet to have to take out an expander because a child is in pain.
Wow. Yeah.
So it is easy. And most parents during that insertion appointment, they're like, wait, that's it? That's all? I'm like, yeah, that's it.
Yeah.
That's it. And there's no impression anymore. It's like the little iTero thing and the digital scan. So everything it's easy. And that's one point that I wanted to make to any of the parents that are listening. This is a really easy process, probably easier than getting your child's teeth cleaned.
I'm really glad you said that. And as you're saying that, and the younger patients, to my orthodontic colleagues who are saying, how dare, we might have lost them at 18 months. True, when you're saying about the age of doing it. But if they're still hanging on and listening, we do nasoalveolar molding. I mean, we do NAM appliances and a Latham appliance and cleft craniofacial. Like, the fact that it's like, oh my God, what's the logic behind ever going in on a patient that young? We have a whole subset of our profession dedicated to this in cleft craniofacial care, where we go in and shape the growth of the face in these patients who have a type of craniofacial dystrophy of sorts. Theirs is associated with the cleft craniofacial anomaly. Why is it a stretch to say, well, if a patient is growing in a similar dystrophic manner and they have this altered craniofacial growth, why should there be an age? And to your point of show me the study, when we were talking before, show me the study that says that there's an age at which you need to wait to start changing and redirecting the growth and development of somebody's face. I challenge anyone out there. I want to see it. I've yet to find it. I've yet to have anyone produce it. But show me the study that says you can't start or shouldn't start redirecting and changing the craniofacial growth and development of a patient that is growing in an aberrant fashion at whatever age you want to pick, right? I haven't seen it. So it's a mindset thing, I feel, in a lot of this. I do really like the fact that you brought that up about the parents, because I don't think I talk about that enough. I get so probably overly frustrated with my colleagues and not seeing this. I tend to get a little hyper-focused on that. And in this is the parents who maybe they're just looking for that provider to tell them it's not a thing too. I mean, to your point, like
Yeah.
it might just be like, well, oh, well, Dr. So-and-so said it's not a thing, so it's not a thing. We have those parents who knew it was really a thing and wanted to be told that it was something so they could get their child help. And there's a lot of other parents, and it's not a comment on their parenting. It's human nature, who are like, I don't want to think anything is wrong with my kid. I don't want to believe there's a problem. And I really don't want to put my child through any treatment, or maybe finances are an issue, or there's a bunch of things. And they're kind of
Yeah.
looking to be told no. So that's such a great point, that this isn't like when you were 13 and had 4 teeth pulled and a palatal expander put in and were treated with stainless steel wires cranking on your teeth, and it was brutally painful.
I think the other misconception that happens is that the quote unquote rapid palatal expander gets a bad name. And that is, again, going back to the fashion that it's used in traditional
Yeah.
orthodontics, which is very rapidly activated,
Yes.
turning a rapid turning schedule. Because I'll have parents come in and say, well, I don't want the expander with the key.
The key.
And
Yep.
I'm like,
Yep.
why don't you want the expander with the key? Oh, because rapid palatal expanders are not good.
Mm-hmm.
Well, the only thing that makes them the difference is how rapidly you
turn it.
expand them.
Right.
The thing itself does nothing if you don't activate it.
Yep.
So there's a lot of misconception about that with parents that know some about this field,
Yep.
but not all of the nuances.
Yep.
Because the expander I use most often has a key, the traditional screw in it, but we are activating it 2 times a week
Mm-hmm.
or 3 times a week, not every day, twice a day. So there's a lot of education that needs to happen in this process too, which, getting back to the point of like, why would I change my whole practice and everything? It's because it also takes a lot of effort and talking effort, because you're doing a lot of the educating as well.
Yeah.
You're not
Yes.
just getting to sit down and talk about a cavity that everyone knows what a cavity is and then go do your filling or whatever.
Or the
You
orthodontist
have to
saying
go-
you need 18 months of braces
Yeah.
and walking out the door. Right.
And then, yes. So I think that is also a factor, but there is a lot of education that needs to happen because we're not standardized yet. There's people coming in with different types of misconceptions, and you'll see, like you talked about my function first model, which is what we kind of practice by.
Mm.
And the first area of that is the family piece. And that's the family story, because I need to know, A, where this family has been and what they're going through, but also what kind of information they have, because some of them have really great information that's accurate.
Mm.
Others have like all the misconceptions that they've come in with, and I have to go in there and undo all of those and then re-educate. So I think that's a big key when you're trying to connect with a family and figure out how you can help them, because it's all about speaking their language.
Yeah.
And knowing their background and where they came from and where they're concerned is going to be your in for educating them and hopefully getting their family the treatment that they need.
Yeah. And therein is another obstacle, truthfully, another obstacle to a lot of providers doing this is, you just said it, the extra time and energy that it takes you to do just that, right? You're now talking about learning about the family and their history and their background. You're talking about doing different and more advanced diagnostic procedures. You're talking about then having to explain a more advanced or proactive approach, which is not something they're used to hearing about. You have to have your team trained to be on board with this. You then have to have systems in place to get them to the right people on your team, or your medical colleagues or functional therapy colleagues, or whatever the case might be. There's so many moving parts and moving pieces. And I did it over time. And it sounds like you did some of that, kind of evolved. And I think what happens a lot of times to some of our colleagues is they hear what we're talking about and they are steering that big ship. And it just sounds so overwhelming to think about having to rebuild and do all of that. I don't know if they get the why. And then there's so many excuses for why they don't need to do it. I feel that's because I get asked so often, Mike, why aren't more orthos doing this? And I've really tried to think about it. And I think a lot of it, I don't feel like it's malice. I don't feel like it's intentional neglect. I feel like it's just putting blinders on and being a little myopic and saying, I've been doing just fine doing it this way. It's working. I don't really want to put that time and energy into doing that. So I'm just going to put my head down and keep going.
Plus, natural human nature is resistance to change. So that it just plays into that. What I will say, and I'm going to make a little plug for myself here, is that if you are interested at all, I teach a 2-day course through the American Laser Study Club. And it is literally, I would say my strength in business ownership is operations and systems. And so our 2-day course is literally start to finish, if you are not doing any of this, it's like a recipe book, playbook of this is how you start. Or if you're doing this and want to streamline your process or incorporate in-house practitioners, it goes into that too, including hearing from the myo, the chiro, and the lactation as to their perspective of their role and how to work within a dental practice. So if anyone is interested and wants to not be, oh my God, where do I start? What do I do? This is a great course to guide you through that entire process. So all of the ups and downs that I went through, this is now the edited version of the streamlined process to get to where you want to go. And our next course is in April in Maryland.
Perfect. I'll put a link in the show notes as well. That way people can get in touch with you. And is there another way to get in touch with you directly if people just have some questions for you?
Yeah. So through my website, westviewpediatricdentistry.com, there's an email link on there. If you email that, I'll get that as well. If you follow us, Westview Pediatric Dentistry or Tanglewood Pediatric Dentistry on Instagram, all of my course information is also on there. I have another ortho course for 6 and under coming up in the beginning of May. That's in Denton, Texas at 5 Star Orthodontics.
Great.
So that's focusing on the screening of all the patients, but also how to treat them, how to appropriately pick your appliance, how to appropriately collaborate or refer to other practitioners. And that specifically focuses on the 6-year and under population. And then if anyone has any other questions or just wants to bounce ideas or anything, I'm here to spread the word and get more practitioners to do more of this stuff. So if anyone's ever in Houston and wants to come by, doors always open.
Well, first off, I don't know how you have the time to do everything we're doing. It is highly impressive because you're a mom and a wife and a business owner and teacher, and it is amazing. And I thank you for being such a warrior on this, because
thank you.
People out there may not realize just how hard we touched on it a little bit, but not everybody is built to withstand that hate and that feedback and that negative press, so to speak, that you can get. And it takes someone very strong and very dedicated and with the courage of their conviction to be able to stand up to that. And we need people like you. It's one of the reasons why I wanted to have you on. Yeah. Kristen Connett was the one who had mentioned to me that you knew of you, and she said, you need to talk to her. And there was 2 people she mentioned were you and David Alfie. And I've now spoken with both of you and I will be messaging Kristen to thank her again for putting me in touch with you both. And I see why she wanted me to be in touch with you, because you're doing amazing, amazing things, and not just keeping it for yourself, but you're sharing it and you're wanting to change. So yeah, I'll put in the show notes all those contacts to your website as well, so that everybody into the course as well. So anything you want to add as we wind down?
No, I just thank you for having me, and it's great to have an orthodontist on this side of things as well. And yeah, I think let's just collaborate and keep pushing this forward.
Yeah, that's what we need to do. And we will. I will end on saying this meeting out in St. Louis at Winds of Change this weekend gave me a lot of hope that this movement is growing, and the people that are behind this movement, all of us, we are not backing down, and we are going to keep pushing for these kids and for these families. And that was very clear in my meeting this weekend and was speaking with you today. So Dr. Pia Gandhi, thank you so much for your time. It has really been an absolute pleasure.
Yeah. Thank you.
Awesome. Thanks. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.